KCBS, in partnership with UCSF Health, presents As Prescribed, a weekly conversation with leading medical experts from UCSF Medical Center and UCSF Benioff Children's Hospitals.
Hello and welcome to As Prescribed. I'm Kathy Novak. We were all reminded during the COVID pandemic just how precious a resource ventilators are in hospitals. And surgeons at UCSF are using a pioneering technique for back surgery that does not require patients to be on ventilators because they're awake. Here to tell us more about it is Dr. Praveen Mumaneni. He is Joan O'Reilly Endowed Professor and Vice Chair of the Department of Neurosurgery at UCSF. Doctor, thanks very much for joining us.
Thank you, Kathy, for having me.
Now, Dr. Mumaneni, to be clear, I'm talking about the pandemic here and how much we all have been hearing about ventilators. This isn't specifically why you set out to do the surgeries this way, just one of the benefits. So can you tell us a little bit more about why patients might want to have these surgeries while they are awake and how it works?
Yes, Kathy. So we started doing awake surgery before the pandemic started. And the reason that we picked doing these surgeries awake is because some patients have problems recovering from general anesthetic. And we found that if we were doing the surgery with a spinal anesthetic and a mild sedative and no ventilator, that they're waking up very quickly, mobilizing very quickly, and leaving the hospital very quickly. So we started to expand our protocol and tried to do more and more cases with these kind of awake anesthetic techniques.
A spinal anesthetic, exactly then how are patients going into these surgeries? What do they need to know about how they're going to be in the operating room, what they're going to be aware of, and what they're going to feel?
Yes, so the patients will come into the operating room awake and talking. The anesthesiologist will then put in a spinal anesthetic while they're sitting up, and then they will position themselves face down on the operating table. They'll still be talking at that point. Then the anesthesiologist gives them a very mild sedative. So they take a very light nap so that we don't have to have full awareness of all the things that we're talking about during the operation. And after the procedure is done, they wake them up from the light nap, and the patients are basically awake and talking as they leave the operating room, and they go into the recovery room awake and talking and completely oriented.
So, doctor, if patients are up pretty much as soon as they're done with the procedure, what does that do in terms of cutting down their recovery time?
Yes, so the recovery time is cut down by 80 to 90%. What happens is they go into the recovery room, awake and talking and fully oriented. They don't have to wait for the effects of the general anesthetic to wear off. And they spend very little time in the recovery room. They head on up to the floor. And by that same afternoon, they're mobilizing. And typically, most of them go home the next day.
Wow, so we're talking about not needing to be on a ventilator, shorter recovery time. We've also discussed on this program in the past the effects of delirium, and I understand that that may be another reason that people might choose to do it this way.
Yes, that's the original reason why we started doing this surgery awake, is because we noticed in patients over 65, and especially in patients over 75 to 80 years old, they're having a lot of delirium with general anesthetic. They have typically some problems with memory on the day of surgery. They may have difficulty with recalling events within a week or two of surgery. For many of these patients, these kinds of delirium effects can last for days. For a few, it can last for weeks or even a month. And so by eliminating the general anesthetic completely, those patients are not having these kinds of delirium issues. And this is really the reason why we started doing these procedures awake before the pandemic started.
So that all sounds good, but who might be the patients who might not want to have it done this way?
Yes, not everyone is a candidate, Kathy, to have this kind of surgery done awake. First of all, patients who have surgery at only 1 or 2 levels, typically L4, L5, or L5S1, are good candidates for this kind of surgery. But there are some characteristics where we tend to avoid this kind of awake anesthetic, and that is patients who have a high level of anxiety or patients who have sleep apnea. For those two sets of patients, we tend to avoid doing the surgery awake because we don't want them to be too anxious during the case. And for the second set of patients, we don't want them to be snoring and having an airway problem while they're lying on the table. So for patients who have anxiety or sleep apnea, we typically will still use the general anesthetic. But for many others, this is definitely an option.
And is it the patient ultimately who chooses what they want to do? What are the conversations you're having there with your patients?
So we created a nice algorithm and protocol at UCSF along with our anesthesia team. And what we did is if we think that a patient is a candidate for an awake surgery and they're willing to undergo that procedure, we'll have the patient evaluated by the anesthesia team. They will check their airway, they'll check their level of anxiety, and then if they sign off, then we'll proceed with the case. So we have to go through a little bit of a checklist before we proceed with the case.
Is this technique widely used across the country? Do you expect more procedures will be done going forward with patients being awake?
Yes, I think there's very few centers currently doing awake surgery, especially for lumbar fusion. This technique is employed in Miami and New York and San Francisco. Relatively few places are offering it currently. But I think as time goes on, more and more sites will pick up this awake option because I think a lot of it is patient driven and a lot of it is learning what algorithms to use for these patients. And our publication recently in Neurosurgery Focus will help people to assess which patients are the best candidates.
And do you think that it can be broadened then to other kinds of back surgeries, other kinds of surgeries in general? Is it a very narrow set of procedures that you could use awake surgery for?
So I think that's a great question, Kathy. We need to typically do these spinal anesthetics at L2-3 or L3-4. We want to do them at those levels because there's no potential for problems with the spinal cord. And so these surgeries are typically done for patients who need surgery from L3 down to S1. So there is some currently limitation in what levels of surgery we want to do just because of where the spinal anesthetics are placed. Now that's the issue now in 2021, but in the future, we may be able to expand the protocol and work our way up into the thoracic area as well. But I think that just comes with time and experience.
And we started this conversation talking about ventilators. Have you had more colleagues coming to you interested in these procedures precisely because you don't need ventilators to do them?
Yes, I think that's a very good point, Kathy. Since the pandemic started, I've actually been doing this procedure on several physicians who specifically want to avoid ventilators. They know that the COVID pandemic has created a shortage of ventilators, especially that happened acutely in the summer of 2020. And so several physicians have been asking for the procedure to be done awake because they want to avoid the ventilators altogether.
And we were talking about people who need these back surgeries, and perhaps I should back up and talk about how did they come to you in the first place? What do people need to know about, spinal health and protecting themselves against getting to the point where they might need surgery on their spine to begin with?
Yes, so I think there's two components to having problems with your low back. One component is genetic, which is very difficult, obviously, for us to change. The other component is environmental. If you do not use tobacco, that helps you to avoid having degenerative disease in your lumbar spine. If you avoid heavy lifting, bending, twisting, especially as you get into your 50s and 60s, that also helps you to avoid having problems with your lumbar spine. I also see a good number of people in their 50s and 60s who are athletic and will do things like marathon running or lifting heavy weights or things like that. And those folks typically will have problems over time in their lumbar. So it's a lot of it's back biomechanics that can be done and staying in good shape, to avoid having problems with your low back.
Always a good reminder. Thank you very much for joining us, Dr. Momineni.
Thank you for having me, Kathy.
Dr. Praveen Momineni is Joan O'Reilly Endowed Professor and Vice Chair of the Department of Neurosurgery at UCSF. And I am Kathy Novak. Thanks very much for tuning in to As Prescribed.
As Prescribed, every Thursday at 1:30, right here on the Bay Area's news station, All News 106.9 and AM 740 KCBS, and streaming on the Odyssey app. The proceeding was sponsored by UCSF.